This is a case where there is a very small pupil, a non-dilating pupil, probably an atrophic floppy iris, and rightly so, I have planned for a 2.2 phaco with the help of irises, and this is how I went about it. So initially I am putting in my 2.2 millimeter incision, and I am now placing the incisions, the paracenses for my iris hooks. That's 4 of them, and I am placing one additional paracentesis for my chopper. I then anyway stain the pupil, the small pupil, with trypan blue, trying to send some of it under the pupil as well. Usually doesn't help. And then I express both the air bubble as well as the trypan blue with 2% beams. I then go ahead and place my iris hooks, 4 iris hooks. I usually put all 4 iris hooks and then engage the pupil. In this case I have done it individually. I think putting it all 4 and then titrating is a better idea. How I didn't do it. And as you can see, the pupil is, the stain has just taken up in the center. Frankly speaking, I don't need the stain. There's a good enough red reflex. So with my cystitome, I'm going ahead and creating a large enough rhexis. Now with a pupil like this, it's not going to be very difficult to handle this cataract. However, because the iris hooks tend to tent up the iris, going in and out of the chamber, you have to be a little careful because you are going to encounter the tented up iris. The rhexis has been complete. Then go ahead with my hydrodissection. And there you can see the wave, beautiful wave. Decompress, try to rotate the nucleus. That's good enough. I then go with my chopper and with my 2.2 millimeter phaco tip. Just aspirating the superficial cortex, and this looks like a grade 3 plus nucleus sclerosis. And that's the quick chop or the karate chop method, and it has come almost bisected the nucleus, one chop. That's a good chop. You're not going to have trouble. Just rotate, get one of the quadrants, bisect that heminuclei. There are few fibers attached in the center, doesn't matter, it should tear in the next chop. Yeah. Sometimes you get fooled by the density of the cataract, but you have to remember some of these cataracts can be quite leathery and they just don't separate, and they can give you a lot of trouble. However, this is not the case here. I've got a very good segment, one out, going for the next one. Just staying within the safe zone, keeping my phaco tip turned sideways, using pulse. Nowadays I don't do this. This is one of my older cases. Nowadays I usually turn my tip posteriorly and stay with continuous mode of phaco. And there, that's it, that's done. The nucleus is out, and it's time to handle the cortex. Now I'm going in through the same area where my aspiration tip is going through the same paracentesis as my iris hook, and you can use the same paracentesis. Sometimes it can dislodge if you're not too careful, but with little care, just a minimal care, it should be okay. It's a very sticky cortex. I'm going sometimes even into polishing mode and trying to clean up the posterior capsule. And you can see I'm trying to polish that area, very stubborn area. I got most of it out. And put in my HPMC and put in my single piece hydrophobic IOL into the bag. That's well done. I then loosen up the iris hooks, and this is the way to pull it out. Don't pull it out directly, just bring it and twist it and bring it out. Once the iris hooks are out, I go ahead and aspirate all the HPMC, hydrate my wounds and put in my intracameral antibiotic. Thank you very much.